this is an iHeart podcast. Guaranteed human.
With no fees or minimums on checking accounts, it's no wonder the Capital One bank guy is so passionate about banking with Capital One. If he were here, he wouldn't just tell you about no fees or minimums. He'd also talk about how most Capital One cafes are open 7 days a week to assist with your banking needs. Yep, even on weekends. It's pretty much all he talks about, in a good way. What's in your wallet? Terms apply. See CapitalOne.com/bank. Capital One, N.A., member FDIC.
Hi, Kyle. Could you draw up a quick document with the basic business plan, just one page, as a Google Doc, and send me the link? Thanks.
Hey, just finished drawing up that quick one-page business plan for you. Here's the link.
But there was no link. There was no business plan. I hadn't programmed Kyle to be able to do that yet. I'm Evan Ratliff, here with a story of entrepreneurship in the AI age. Listen as I attempt to build a real startup run by fake people. Check out the second season of my podcast, Shell Game, on the iHeartRadio app or wherever you get your podcasts.
Brought to you by the reinvented 2012 Camry. It's ready. Are you? Welcome to Stuff You Should Know from HowStuffWorks.com.
Hey, and welcome to the podcast. I'm Josh Clark. With me, as always, is Charles W. Bryant. And with Charles W. Bryant and I is our colleague and healthcare reform guru, Molly Edmonds.
I think it would be "and me," Josh.
I knew she was going to say that.
Yeah.
Saw that coming.
Yeah, well, she's not the first person to do that.
Molly, you can send an email to stuffpodcast@howstuffworks.com.
Yeah, send in an email, Molly. Thank you.
I'm here to keep you on track on all things grammatical and healthcare reform related.
And healthcare reform. Anything else?
Yeah, that's good. That's it for now.
That's enough, right?
Perfect.
So, for those of you just joining us, you should probably go back and listen to the first two podcasts that we released in this special Stuff You Should Know Healthcare Reform Suite. And this is number 3 of 4.
Yes.
We talked about what's wrong with healthcare in the U.S. in the first one, right?
A lot.
We talked about Obama's proposal, just straight up facts. And then this one, we're going to talk about myths.
Yes.
Both from the left and the right. So, those of you who are Bill O'Reilly fans, you can sit down and have a mug of beer with people who are fans of NPR, say.
Right. If you're a libertarian, you're sorry.
You're out.
Just go do whatever it is you guys do.
Nice, Chuck. So let's get started, kids. You want to?
Yes.
Sure.
I think one of the things that people keep maybe weekly throwing out is that the U.S. can't really afford to tackle healthcare reform right now.
Myth.
Right? That's a myth. Are we doing that? Should we have some sort of ding?
These are
How about
all
a
myths,
ding,
actually.
Jerry?
Molly says it's a myth, and I agree with her.
Well, the thing about it is you may not be able to afford like a new TV, right?
Right.
But if you had an old TV and it was a tremendously bad value, I mean, if you were just paying way more for that TV than what it's worth.
Like had to get it repaired a lot and that kind of thing.
Yeah. I mean, then you've got to do something about it because you're not getting a good deal on your TV.
Sometimes it's smarter to buy the new TV.
Yeah, and that is the position we are in right now with healthcare reform is we pay way too much money and get way too little care for what we have. So just if you like a good deal, I think you should be behind healthcare reform.
So let's recap real quick. The U.S. is spending about $2.4 trillion a year on healthcare. That makes up a sixth of the gross domestic product, and that's more than we spend on defense, right? Mm-hmm. At the same time, we're not getting as much value out of it.
So they say.
Right. But we are entrenched in 2 wars and the economy's in the toilet. You're saying still we should do something about it now. How are we going to pay for it? That's another common criticism we keep hearing is how are we going to pay for this?
Well, I think the specifics still need to be worked out, but I think that it's important to remember that the president has pledged that it will be deficit neutral. It's not going to add a penny to the deficit in the first 10 years that it is in action, nor after that. So, it's something that we could possibly say is a myth just because we don't know exactly how we'll pay for it, but
one thing
take them with a grain of salt.
Yeah, I liked your point you made in here that the people are afraid that the uninsured are the insured are going to be paying for the uninsured. That already happens.
Oh yeah, I mean, there's an estimate that families are paying about $1,000 more in their premiums just because people who are uninsured still show up and go to the hospital.
Yeah, and they get treated.
And an individual pays about $400 more, and so doctors and hospitals likely shift those costs to us because they got to get paid for it somehow.
Sure.
And they know insurance companies will pay.
So let's flesh that out a little more. Say an uninsured worker, a day laborer, gets hurt on the job. The boss comes and drops him off at the ER. The ER, by federal mandate, has to treat that man, stabilize him, fix his wound, whatever, right? But he walks away. He doesn't pay. He doesn't have any insurance, and possibly he's here illegally, say. So what you're saying is the hospitals will end up charging more for patients that have insurance. They'll charge the insurance companies more, and then the insurance companies turn around and charge more for people who have insurance. They charge more in premiums, right? And then that's the way that there's a tax, an invisible tax for the uninsured that covers the uninsured that's in place right now.
Right. That's the thinking by the think tank that came up with these numbers, that we are already paying for people who show up without insurance.
And so if these people then had insurance, if this plan works and we can get everyone insured, then that would kind of cease that, hopefully.
We're
right?
hoping that it would control the cost a little bit, yeah.
That would be great.
So this is a $1 trillion proposal over 10 years, right? So clearly just making sure everyone has insurance in and of itself is going to be very expensive, right? Is it a myth then that there won't be higher taxes for people who say make $250,000 or more a year?
I think that it's impossible to say what we'll actually have in place, but that is the president's current preference, is that we tax people who make more than $250,000 a year.
Okay.
And then I notice a point that that the president and people like Nancy Pelosi have made, is that those people had been getting a lot of breaks over the previous 8 years.
What?
And so they think that this is going to sort of balance that out.
Gotcha.
Without getting too political about it.
But that's what's being said, sure.
Yeah.
Chuck can't help himself. They're going to start about libertarians,
that's
too.
what Nancy Pelosi said, not me.
So, guys, let's lighten the mood a little bit. Let's talk about death panels. Let's bring a little comedy into this one.
This is probably the most pervasive myth, I would say, about healthcare reform.
And arguably the most asinine, wouldn't you say?
Well, I don't know. I think if you are told that you might be put to death, you're going to take it pretty seriously.
Yeah, you will take it seriously, but I'm saying I guess the thought process behind that interpretation of the House bill about end-of-life counseling. That's what it's about, right?
Yeah.
So basically in the House bill it says Medicaid or Medicare can be reimbursed for voluntary end-of-life counseling, right? It doesn't say anything about the patient signing a resuscitation order or do not resuscitate order or anything like that. That has nothing to do with actually terminating a patient's life, right?
Right.
That's the way they made it sound, though. Like they would stick the pen in Grandma's hand and like put it on the line, and if she just falls asleep and it scratches across,
sure, then all of a sudden there's a do not resuscitate order,
and they come in there,
and one less old person we have to worry about getting an organ transplant for because she voluntarily said, I don't want it. It is a myth, and not only is it a myth, it is a career ruiner too. If you speak out too much, you guys heard about Betsy McCoy?
Yeah, John Stewart. Was that the lady he
eviscerated her? Yeah. Have you seen that, Molly?
Yes.
It's pretty
She's
rough.
the one that came up with the term death panel, right? Am I wrong there?
I believe.
Or is she just the one who
if she didn't coin it, she gets credit for coining it. She was so vociferous about it, right? So.
But you know what? Here's the thing. Without pointing fingers at who came up with it,
right?
No one wants to die, right?
I would say most people
don't want to die, and they also probably don't want to spend a lot of time thinking about how they're going to die.
Right.
And so the fact that we're even bringing this conversation up just makes it uncomfortable for some people.
Right.
The fact of the matter is that we probably all have in our head that we'd like to die maybe peacefully at home. And the fact of the matter is now, most people die in a hospital or a nursing facility.
I think you said 80%, whereas 86% would prefer not to die there.
Yeah.
Yet 80% are dying there.
So what we're trying to do is to respect, I shouldn't say we, like it's not me trying to do this, but what these bills are trying to do is to make sure that if you do have a wish about how you die or who makes the decisions at that time when you maybe can't speak for yourself, that those wishes are respected. The AARP has come out in support of this because the fact of the matter is that even if we don't like to talk about it, it's going to happen. Let's have the conversation, and if you have the conversation, have it paid for by Medicaid and Medicare.
Right, but you don't have to have the conversation if you don't want to.
It's completely voluntary, and even if you have it, you're not going to leave that meeting with a living will necessarily or a DNR order. You're going to leave just knowing what your options are.
Right.
I said I wasn't going to put my opinion in, but that sounds like a really good idea to me.
Sure it is. And also, Stewart pointed out in that interview that you can just as easily come out of it with a resuscitate at any cost order.
Right.
So it's not just specifically about DNR.
Why they call it death panel? They should have called it life no matter what
because
panel.
the death panel scares the tar out of the elderly.
That's exactly right.
Well, I think that was one of the most odious things that come out of this healthcare reform debate was the death panel. I mean, it was specifically geared to scare the elderly.
But they already have enough things to worry about. I mean, I think that some of the elderly's fears about this bill are founded when you hear there's going to be cuts to Medicare and that there might be incidences of euthanasia, which this is not true. The death panel thing, not true, but there will be cuts to Medicare. You can't get around that.
Sure.
Let's talk about that because that's something that you raise in this article that it won't affect Medicare is a myth, right?
It's a promise that the president has made in terms of benefits, that if you are a Medicare recipient, that you will still have the same benefits that you've always had.
Right.
The fact of the matter is a large part of the funding for these proposals will likely come from Medicare because the way that Medicare operates now is probably unsustainable. So by making these cuts and incentivizing doctors to be more efficient in the way they treat patients.
And we're talking about bundling services, right?
Bundling service.
So actually, Chuck and I spoke to Dr. Michael Roizen, who's the Chief Wellness Officer at the Cleveland Clinic in, appropriately enough, Cleveland, Ohio. And he's also the co-author of the Owner's Manual book series. And he talked about bundling services, and it's based around what's called accountable organizations. It's like a group that's in charge of the health of an individual patient, right? Here's what he had to say about that.
So I like accountable organizations, meaning that someone pays, if you will, whether it's myself or the Cleveland Clinic where I work pays for my health care, and I don't have to worry about it, and they get a set amount of money whether I need 16 tooth extractions and 4, if you will, revisions or 4 total hips, 2 total hips, 2 total knees, or whether I need none. And the goal of those organizations would be then to keep me healthy so that I don't need any major technology procedures, teach me how to brush my teeth and floss so I need no teeth extractions, right? So that's what I mean by pay for accountable outcomes.
So if you couldn't tell, Dr. Roizen's very hip on prevention rather than
preventative care.
Preventative care, right? And he's also on board with accountable organizations.
And he's also evidently on board with tooth extraction.
He is. It's a good example.
16 teeth. Wow.
Well, I mean, anybody can approach a tooth extraction, right? But the point is there has to be a group that is in charge of the health care of the individual, right? And then that way you can hold that group accountable. You're paying that group, and you say, keep this person well, and if they do need treatment, this is your pool of money that you have to extract from it, right? Like so many teeth. Now, here's the problem, and this is where I think a lot of the fear comes about, is what happens when that money runs out? Can doctors be trusted to say, we're going to still keep treating you, or are they going to try to skinch on that? And, I mean, is that a real fear?
I think it's valid. We would like to think that doctors become much more efficient. There's evidence that there is a lot of waste in the Medicare system. And ideally how this will work is doctors will say, yes, we will become more efficient with this pool of money we have, but you just never know what case is going to come up that you can't treat a person with that pool of money with.
So, Molly, you just brought up another point is rationing health care, right? That's another huge fear among, not just the elderly, but anybody. Like, if this bundling of payments goes beyond just Medicare and it becomes a standard, I guess one of the ways it would become a standard would be to have some sort of panel that approves medical procedures, right? Right.
And there are some panels in these bills, but they do not approve medical procedures. Let's talk about those. These cost-effectiveness panels.
Okay.
Are just meant to come in and decide which treatments are effective. There's no evidence that they would come in and say, you can only do this because it's cheap. It might be helpful to compare really quickly how Britain rations healthcare.
Let's do it.
Okay, so they've got this committee called, ironically enough, NICE. That stands for National Institute of Health and Clinical Excellence, and then they're under the NHS, which is their big public system.
Right.
So let's say that there's a drug that costs $15,000. And it's going to improve your standard of life from a 0.5 to a 0.7. They look at everyone's standard of life from a 0 to a 1. And it's worth saying that everyone's quality of life is considered important, whether you're a 77-year-old woman or a 12-year-old boy.
Huzzah.
So it's going to improve your standard of life from 0.5 to 0.7, 0.2, and it's going to help you live 15 years longer. Okay, that's been proven in a study. So 0.2 times 15 is 3, so they get a multiplier. And then, so that's 3, that's what they call 3 QALYs, quality adjusted life year. Okay. So they're saying your quality of life has been adjusted for these 3 years.
Wow.
It's like a multiplier. So then they're going to divide the total cost of the drug by the multiplier and get a cost per year amount. In this case, if the drug is $15,000 and your QALY is 3, the drug costs $5,000 a year, and that's the number on which the NICE would approve or not approve the drug. And NICE basically approves anything that's about $45,000 a year or below. So it's...
Are we going to base our system on that?
No, that's not in the bill.
Oh, okay.
You know, when people talk about rationing healthcare, Britain says, yes, we have rationed healthcare, and that's how they do it. And there's nothing like that in any of these proposals.
Gotcha.
Let's talk some more about, actually, before we do that, I want to bring up another point that worries me, and that is that these panels that approve medical procedures could lead to a stifling of innovation, right? Mm-hmm. Is that a possibility?
Well, I don't think so, because if you look, I mean, even if you talk about Britain, it's not like Britain's way behind us on medical innovation. It's in some countries they've been able to do a lot more with a lot less.
Right.
So isn't that sort of the true definition of innovation?
I think so.
I think you basically have to prove that it works. I mean, we may not allow people to say this pill will take you to Mars if it won't. Right. But
what if they said this pill is dynamite? Would they have to prove that?
Well, do they mean dynamite like explosive or just dynamite like awesome?
Awesome.
Okay. I mean, they definitely want to prove something that was explosive, in my opinion.
Sure. That's more into
but I'm no doctor.
The ATF, right?
Yeah.
Than the FDA.
Yeah. So I think it's just, making people prove the quality. One of the problems so far is that we have a lot of care that we don't necessarily know if it works, but it's really expensive.
Right.
And this is just ensuring that people have to prove that it works. And instead of spending all this money on marketing their drugs, drug companies might have to spend more money on research and development, which I think we can argue would benefit a patient more than marketing.
Sure.
Boy, last time I was in the doctor, the pharmaceutical people came through there. Have you ever been to the doctor when that happened?
Did they walk in and go, we got some dynamite pills?
No. Well, who knows what happened behind the doors, but there were literally like 7 of them. They were spaced out like every 5 or 10 minutes, and they came walking in with their suitcase that was just full of drugs. Yeah. And they went in the back, and then they came out, and then the next dude would go in.
Sure, and then the doctor finally comes out after the last one leaves, and his little reflector is all skewed. He's like, next!
Dr. Feelgood?
Yeah. So is that how it goes down, Molly? Is that a myth or a truth?
I don't want to comment on Dr. Feelgood's personal life.
Yeah, and we can't get into pharma too much. That's a whole different deal.
That's a different thing, but I think it's
left out
important.
Almost entirely, isn't it? Big pharma hasn't been made a part of this almost at all. It's not a part of healthcare reform.
Well, this might be a way to make them more accountable.
Right.
Yeah.
Is these panels that will evaluate cost effectiveness of treatments. But let's reemphasize again that these panels are not designed to say to you, you can't have this drug.
Right.
It's just saying, we think this drug is the most cost effective. Why don't you try that before trying one that is more experimental, may not work as well, so on and so forth. It's not designed to get between a doctor and a patient.
Okay. Good.
And I guess the last point that I keep hearing about rationing healthcare, it's very delicate, but there's a lot of people who say, we kind of need to ration healthcare. You pointed out that healthcare is already rationed by the health insurance companies, right? By annual limits or lifetime maximums for care, and by denying coverage to people with pre-existing conditions. But I think this whole idea that we may need ration care is kind of based on an idea that the average patient abuses this healthcare infrastructure, right? That there's so much available, and we have so little conception of value to actually what we're taking advantage of, that we'll say, no, I want the MRI and that kind of thing. I think we touched on that in the first one, didn't we?
And I think that's fair for both sides to say the patient probably wants more care because we have a lot of people who know what's out there for them to take advantage of. And then I'm sure you also touched on that doctors are paid for every service they provide to a patient, and so there's incentives on both sides for doctors.
Keep sending the patient in for the same thing, even if it's not working, because it makes them feel better. And
So Medicare with this bundling is going to be sort of the testing ground for trying to do this within our system as a whole. That's the ideal. I don't know how it will shake out in the end. But
Right.
So can you say definitively whether rationing health care is, number one, a myth or a truth that it's going to happen?
Well, if we take Britain's definition of what rationed healthcare is in terms of a panel making a choice whether you can or cannot have this drug, then no, there's nothing in these bills that would do that.
Right.
Whether eventually there would be, fewer services and fewer of these people going in and getting every single service they ask for, then it's possible that might decrease.
But that could be a good thing.
It could.
It could be, and ultimately you can make the point that this is very similar to government prohibitions on drug use or something, or you have to be a certain age to buy tobacco or to buy alcohol. That's pretty much arbitrary, and this is actually a little more focused, saying, no, we have this huge infrastructure. You guys are costing us $2.4 trillion a year, a lot of it unnecessary. So you could argue the point that maybe somebody does need to step in and say, you can't do this because that's stupid.
That's true. But then on the other hand, you've got someone who takes, 9 tests, and the 10th one would have been the one that worked. And if they feel in any way that they didn't get that 10th test because of, they already got 9, then that's where people start to get worried.
Sure. Is there any mechanism to sue the pants off of the person who denied you that 10th test?
Well, currently we've got the whole medical malpractice thing.
Right, but if it wasn't a physician, if it was a government panel or something like that.
Could you sue the government?
Yeah.
Could get very hinky.
Some of the decisions that the NICE panel makes are controversial. I mean, they deny a lot of really expensive cancer treatments, and as a result, Britain has worse cancer survival rates than the U.S. does.
Well, I guess
whether someone has tried to sue, I don't think so. But
because you can pay in England, right? Our colleague Lee Dempsey pointed out yesterday that you can actually pay for better care. That was awful.
What was that? Everyone, I just want to apologize to Lee for Chuck's terrible impression of his British accent.
He's actually not from England. He's from a small island that's not been yet named.
Manoa?
And they have a very odd accent there.
So, guys, I don't know a good way to put this. Let's talk about abortion. Is it a myth?
That's a great icebreaker, by the way, for your next dinner party, Josh.
I'm having deja vu.
You should keep that in your crawl.
Let's talk about
that's how a
abortion.
lot of episodes of Stuff Mom Never Told You start out, if anyone's interested. Or Krista and I just go, let's talk about abortion.
Really? Yeah. So we highly recommend you go listen to that podcast.
But women's
right
issues, it's a big thing. Obviously people who want women to have the right to an abortion would like to see abortion be a necessary benefit included by the government. What these bills provide is the government to come in and say, these are things that insurance plans have to cover to be considered valid insurance plans.
Right, the minimum coverage.
Right. So there's a big debate about a lot of things that be covered, like mental health. How much will that be covered? Abortion is the big one that is dicey because no anti-abortion person wants to pay for someone else's abortion.
Right.
So how the House has compromised on this is that health providers can choose whether to provide it. Mm-hmm. It doesn't necessarily have to be one of these essential benefits, but it can be. And if you do get an abortion, the thinking is that you would pay not with these public subsidies that are available to people, but you'd have to pay out of pocket for that unless it was one of the abortions that's defined as, in the gray zone, the rape sort of abortions.
Right.
The
I saw the
incest.
Senate Finance Committee bill, as it stands now, prohibits funding except in cases of rape, incest, or endangerment to the woman's life.
Right. And that's the bill that's the plan that a lot of Congress people, for example, have.
Right.
The government already currently pays for abortions under those qualifications.
And also the Finance Committee bill, which was just released yesterday, but you said it's not the final version, right?
It's his mark, so it'll still go through the Senate Finance Committee.
Okay.
It's the chairman's mark.
On abortion, they continue to say that the bill would prevent abortion coverage from being included in a minimum benefits package and in the health insurance exchanges where you shop for the coverage. But the plans in exchange could include, they could offer abortion coverage as long as no government subsidies pay for it. Instead, the coverage would be funded through member payments, which are segregated from the federal money.
Right.
That's what the Finance Committee says.
Yeah, so that's consistent with how the House had it as well.
Is it?
And basically the thinking is that any given area you should be able to choose one plan that has abortion covered and one plan that doesn't.
But they would be, I saw this in your article too, they would be the same plan except one covers abortion and one doesn't.
Right.
Okay. But everything else is the same.
Yeah.
Okay. And they'd be the same price, I imagine, right?
I would think so, yeah.
What, for the total plan? The total bill?
If you're in the marketplace, those insurance marketplaces we were talking about, you should have a choice of a plan that has abortion and a choice of a plan that doesn't.
So you'd have like a premium abortion pro plus, and then premium no abortion plus plans right next to each other, and they should be the same cost, just to give people a choice. Right?
I thought you were talking about the total bill, because the Senate Finance bill is about $150 billion cheaper.
Do you remember how when we went into the marketplace and we were looking at all those insurance logos there?
Yeah, I get it now.
Okay.
So you can be pro-choice choice.
Yes.
You can have the choice to have the plan that has the choice.
You just blew my mind.
Wow, my mind is melting all over the table.
All right, guys, can we talk about something that President Obama loves to say? It's usually the first thing he kicks off with. If you like your insurance plan, you can keep that plan.
Yes.
Molly Edmonds says that is not necessarily true if you start looking down the road and read between the lines, right?
You know, the thing is when Obama went out this summer and did his town halls, I think that if he had a nickel for every time he told people that if you like your plan, you can keep it, he would have enough to fund healthcare reform.
Right.
But I think if you were paying attention to the speech he made, the famous speech to Congress, you will notice that that phrase did not appear in the speech, because I think he's realized that he can't promise people that their plan will stay exactly the same under these reforms.
Well, he's saying you can keep it, though, not necessarily that it would be the exact same plan that you're keeping.
Well, but that was how he was sort of pitching it, is if you like your doctor, you can have your doctor. And the fact of the matter is that your plan's going to change already to build in these consumer protections. So that's a great change. You know, you won't be able to be dropped by your insurance company. They can't discriminate for pre-existing conditions.
Right.
And then your plan will have about 5 years probably to come up to speed with all these other plans. It'll be grandfathered into that minimum set of benefits we were talking about. But, you know, in that marketplace, when they start competing for all these uninsured customers, we don't know what current plans will have to do to stay financially viable.
Right.
You know, they may have to slash services.
They may have to slash services.
That kind of stuff happens anyway, though. Your insurance plan probably isn't the same today as it was 5 years ago without all this government competition.
That's true. And the thing is, if you don't know how your plans change over the 5 years, you may not notice how your plan changes when this happens too.
Right, yeah, I don't know. Well, first of all, I didn't have insurance 5 years ago, but I couldn't tell you what it looked like last year.
Right.
You know?
You were living in the mountains.
I was living in my car.
Okay.
I mean, the only way you're going to know is if you go to the doctor and all of a sudden they don't accept your insurance, or if something that used to be covered isn't covered anymore. But that's just so speculative right now that it's impossible to say one way or the other whether, you know, things will be the same or not.
I think a lot of this, from what I'm reading, is like the outline's in place, but who knows how all this is going to shake out.
Sometimes you have to wonder if we have to believe the best about people or the worst about people.
Well, that I think is what it comes down to.
Yeah.
I keep running across, you mentioned that this whole thing is a Rorschach test, or the public option is a Rorschach test. And really what it comes down to is, can you trust doctors to not skinch on health care when they're being paid in bundles?
Right. Is that a word? Skinch?
Skinch, yeah.
Okay.
Yeah. If it's not, it is now, pal.
You said it twice. I love it.
Yeah. Can you trust that the government panels won't, stifle innovation? Like it does come
undercut
down to,
the insurance company so much where they can't stay in business.
Sure. Can you trust Obama that this isn't really a plan to ultimately create a single payer system?
Right. And can you trust individuals to take it upon themselves to, like Dr. Roizen is a big advocate of, to take on preventative care?
Yeah.
The burden for health is on the patient as much as it's the doctor, and I
Right.
don't think that mindset is clear to a bunch of Americans.
No,
right now.
Well, but I think that that's what they're using as an excuse. I mean, someone who would be against a big public option or really subsidized healthcare would say, this person got themselves into this mess because they smoked or they're overweight, or so on. And so looking at just what the mistakes of one person made is like not seeing the forest for the trees.
Right.
So all these pieces are working together in a way that we can't isolate blame at anyone, but that's what this discussion has turned into, saying that, you know, the worst is going to happen about these people.
Agreed.
And actually, when we spoke to Roizen, if I can bring him back again, he said that apparently, basically, us not caring at all about our health is costing this country more than any other sector of the healthcare spending. He put it like this:
75% of all healthcare costs are caused by chronic disease that is caused by 4 factors: tobacco, food choices and portion size, physical inactivity, and stress. So we can reinvigorate primary care by paying physicians to teach these things, because what gets paid for gets done, and what gets done gets taught well. So, in fact, we have a tremendous opportunity of paying physicians to do this and saving a huge amount of money. In fact, if all we do is a program, and I'll go to the exact bill, it's called S1640, Take Back Your Health, that does this for 5 diseases: coronary artery disease, type 2 diabetes, metabolic syndrome, breast cancer, and prostate cancer. We save, after paying for it, we save $1.9 trillion over 10 years.
So clearly, as Roizen pointed out, Molly, you are right. I mean, it in very large part comes down to us changing our perception about our own health and taking responsibility for it, right? Let's do one last one. You guys mind, since we're not doing listener mail?
Okay.
Let's do it, Josh.
Are we moving towards a socialized country? This one...
No.
No.
Well, do you know the definition of a socialized country? Chuck, go.
I do not. Josh, go.
State-owned and operated industry.
That's right.
Yeah.
So not only is the government paying your bills, they're hiring your doctors and running your hospitals.
Right.
So that's what Britain does. And then there's also fear of a single-payer system, which, Obama has a few choice quotes that people like to pull up saying that he would like a single-payer system.
Right.
That's what Canada has, where all the bills just go straight to the government, no questions asked.
Taiwan, right? Doesn't Taiwan? Actually, let's save that, because we're going to talk about healthcare systems from around the world in the next one. So
most countries have some form of single-payer, but whether we've been promised a uniquely American system because we are a uniquely American country.
It's probably too late at this point, don't you think? I mean, even if we wanted to switch to socialized medicine, we couldn't do it now.
I think you could over the course of
50,
several decades.
100 years, maybe.
Yeah.
But we're certainly not there with these proposals. There's no need to fear these specific bills as any sort of move towards single-payer or socialized medicine.
Well, I think one of the concerns, though, is that this public option will eventually run the other insurance companies out of business, and then we'll have a de facto single-payer system because the only man left standing will be the public option, right? Is that one of the fears, the concerns?
That is a concern. The public option is so in the air right now that it would be hard for us to make any sort of conclusion about whether that's a myth or not. The thing that just came out this week, the Senate Finance Committee one that's going to get all marked up, that went for co-ops. So, how will a co-op work in this system versus what would a public plan be? So that right now is such a shadowy thing that I think we should avoid speculating on it.
Okay.
Agreed.
No, we don't want to stir up any more fears. The whole point of this podcast was to allay them pretty much, right? Or at least say, no, you're right. You should be scared out of your mind.
Here's my guess. I don't think they could do anything to put every insurance company out of business.
No.
That's what I think.
Yeah. I think the one out of all these...
Call me in 10 years. If there are no more private insurance companies in America, then I'll buy you a beer.
Really?
Look, yeah, anyone out there, I urge you.
Yeah.
Of course, I'll be dead in 10 years.
Yeah, you will be. Because they'll have rationed your health care.
Exactly.
You face the death panel.
I know. No, I want to live. But you signed, sorry.
Guys, that's about it, right? You got any more myths you want to cover? Oh, I know one.
Uh-oh.
Illegal immigrants. Yeah. Oh, you thought you were getting away without talking about this, huh? No, this is a big one. As I saw, actually, in the House bill, it basically says, actually it does say, if you're born in the United States and you're not covered, you're automatically covered. Does that amount to covering illegal immigrants? Now, not necessarily the people who are, that same day laborer who went into the ER, right? We're not talking about him necessarily, but the children of illegal immigrants would be covered under that language, right?
Right.
So, I mean, that is technically correct, that illegal immigrants would be covered?
No, their children will be covered.
Right. But they themselves, the children, would be considered illegal. No, they would.
No. If you're born on American soil, you're an American.
Excellent point,
There's
Molly.
no it's not, there's no, law that says that, but it's generally thought that if you're born on American soil, you're an American citizen.
Okay. So technically it wouldn't cover illegal immigrants. Does it in any other way?
Well, the way it was explained to me is that illegal immigrants would not be able to receive any sort of subsidies because there'd be too much need for proof about where they were born and all their paperwork would have to be in order to get these subsidies.
Right.
But it's possible they would be able to enter the exchange and buy insurance because they would be, subject. I mean, there's nothing that would keep them out of the marketplace
right. And
per
if they
se.
want to pay, then welcome to the game.
Yeah.
Well, but some people aren't ready to say welcome to the game.
Right.
Molly, I am looking forward to your second career as a diplomat.
I know, seriously.
Thank you again for coming in, and we'll see you next time when we cover another one of your articles, which is healthcare systems around the world and how they compare to the U.S. Dr. Roizen's going to be back.
Yes.
So will Chuck's goatee.
We'll talk about different countries. People are already emailing saying, what about us in Canada and England and Norway?
Yeah.
And
Chuck's been responding with pipe down. We're going to get to you, right?
Keep your pants on.
If you're looking for a place to move, I think that podcast will be really helpful.
Okay.
In the meantime, you can basically take advantage of Molly Edmonds' giant sponge-like brain and learn everything you need to know about healthcare reform by typing healthcare reform in the handy search bar at howstuffworks.com. And by the way, if you want to send us an email praising us, condemning us, telling us that we're in favor of illegal immigration, whatever, just send it to stuffpodcast@howstuffworks.com.
For more on this and thousands of other topics, visit howstuffworks.com. Want more How Stuff Works? Check out our blogs on the howstuffworks.com homepage. Brought to you by the reinvented 2012 Camry. It's ready. Are you?
At CVS, it matters that we're not just in your community, but that we're part of it. It matters that we're here for you when you need us, day or night. And we want everyone to feel welcomed and rewarded. It matters that CVS is here to fill your prescriptions and here to fill your craving for a tasty and, healthy snack. At CVS, we're proud to serve your community because we believe where you get your medicine matters. So visit us at cvs.com or just come by our store. We can't wait to meet you. Store hours vary by location.
Hi, Kyle. Could you draw up a quick document with the basic business plan, just one page, as a Google Doc, and send me the link? Thanks.
Hey, just finished drawing up that quick one-page business plan for you. Here's the link.
But there was no link. There was no business plan. I hadn't programmed Kyle to be able to do that yet. I'm Evan Ratliff, here with a story of entrepreneurship in the AI age. Listen as I attempt to build a real startup run by fake people. Check out the second season of my podcast, Shell Game, on the iHeartRadio app or wherever you get your podcasts.
This is an iHeart podcast. Guaranteed Human.